Good morning, everyone, and welcome to the first TIRO MDS program for 2025. I am pleased to introduce our presenter, Dr. Ralf Paschke, who is Provincial Endocrine Tumor Team Chair in Alberta. Prior to that, he served as the head of the Division of Endocrinology at the University of Calgary. His journey to Western Canada has been somewhat circuitous. He received his medical training in Frankfurt and also in Southern California. His clinical training in pathology, internal medicine, and endocrinology was obtained in Frankfurt and Münster. He spent 4 years in molecular laboratory of the Institute of Interdisciplinary Research in Brussels. He then became the director of the medical department in Leipzig and was the deputy chairman of the Interdisciplinary Center for Clinical Research at Leipzig. Subsequent to that, in 2015, he moved to the University of Calgary, where, in addition to his clinical and leadership responsibilities, he conducts research in thyroid nodules, thyroid cancer, and TSH receptor genetics. We welcome Ralf as the presenter in this morning's TIRO program. And joining us also this morning is an individual, who has frequent flyer points on TIRO, Dr. Erik Alexander, who is the chief of the thyroid section in the Division of Endocrinology at the Brigham and Women's Hospital in Boston. He is a professor of medicine and also serves as associate dean for medical education at Harvard Medical School. In addition to his special interest in the evaluation and treatment of thyroid nodules and cancer, he also has special expertise in thyroid illness in pregnancy. He's recently served on the ATA Clinical Practice Guidelines Committee for Management of Thyroid Nodules and Cancer, and therefore is a most appropriate discussant for this morning's topic. I will say that we are very pleased that Dr. Alexander is part of the TIRO Medical Board, and we are also joined by Dr. Shaha, who is a very active member of that committee. In addition, I will say that Dr. Alexander and the THANC Foundation have a relationship that goes back before Dr. Shaha was involved in clinical medicine. That was some 20 years ago. And so we've had ongoing relationship with Dr. Alexander and appreciate his efforts. And so with that, Dr. Paschke, I would love to have you share your screen and looking forward to your presentation.
Okay, so thank you very much for the kind introduction. So these are my disclosures. So to start with, I think it's important to note that the marketing of molecular tests in the United States is, in fact, our clinical practice showed very different results. Calgary have not been 100%, but 21% and 56% for Bethesda 3 and 4. And this reflects our malignancy rates of 26 and 43%. And it is, of course, very difficult to further reduce these low resection rates with molecular testing. A recent publication has shown that following the introduction of the ATA guideline in 2015, there was a reduction of thyroidectomy rates in the US, and these data are based on billing data analysis. Then these same authors used interrupted time series analysis and showed that there was no additional reduction of thyroidectomy rates after the rapid introduction of molecular testing in the United States. These data cast doubt on the claimed and calculated NPV and benign call rates for the respective tests used in the United States. And this was reason why I was asked for an editorial to answer the question, why did this rapid increase of reflex molecular testing of indeterminate fine needle aspiration cytologies in the United States not impact thyroidectomy rates, and what are the lessons learned? Well, the main lessons learned are, as we just discussed, this wrong assumption for NPV and benign call rate calculations that all indeterminate thyroid nodules would undergo surgery without molecular testing. That was never the case. Moreover, another point is that all of these validation studies for molecular testing only reported molecular histology correlations, and there's no data in any of these publications on upstream ultrasound or cytology malignancy risk stratification of these nodules. Also, there's no reports on the use of repeat FNA, which is able to result in a definitive diagnosis in about 50%, and you can in this way then limit molecular diagnostics to only half of the indeterminate FNAs. Another problem is the binary interpretation of RAS mutations. So RAS mutations in benign thyroid nodular disease were simply interpreted as a pre-malignant finding, which was then interpreted as a true positive for the respective test. However, this may be clinically inappropriate, as I will show later. Also, there are several reports for an increase of indeterminate cytologies after molecular test implementation. Our approach in Calgary was very different from the beginning. We used molecular testing following an optimization of our diagnostic pathway for indeterminate thyroid nodules. So the first thing that we did is we evaluated the quality of our ultrasounds and discovered that only about 15% of our ultrasounds were or allowed to risk stratify thyroid nodules. This then resulted in implementation of guideline-based use of either ATA or TIRADS classification of thyroid nodules. This was not only based on reading guidelines, but on actually implementing guidelines. So the respective technologist for the ultrasound is forced to address all 5 malignancy criteria for an ultrasound based on a drop-down menu. And only this allows then the radiologist to issue a report. So this was the first major change. The next major change was evaluation of the malignancy risk for our cytologies according to Bethesda guidelines. This then allowed to counsel patients for their respective malignancy risks based on FNA cytology results. And only after all of this was done, we then implemented our molecular test, which is TIRO-SPEC, which is a mass array test based on multiple PCRs for the most frequent 150 mutations and rearrangements. And instead of further describing the problems, I think it is more constructive to simply describe our way, how we used molecular testing as an add-on, as an adjunct for our diagnostic pathway for indeterminate thyroid nodules. And what I will report on is our experience for the first 2 years we now also have 3 and 4 year data, which more or less confirm these. Initial 2-year data were based on 615 patients. Most of them were Bethesda 3. 185 underwent diagnostic surgery. And we not only report the results for those for who we have histology correlation, but we also report the results for those that underwent surveillance. And the first result is related to repeat FNA biopsies. And as you can see, a considerable number of Bethesda 3 and 4 cytologies can be diagnosed as a definitive diagnosis with repeat FNA cytology alone. And that was the case prior to implementing molecular testing and also after implementing molecular testing in Calgary. So bottom line is that repeat FNA of B3 thyroid nodules, the most frequent cytology diagnosis in Calgary, results in a benign diagnosis in about 50% of thyroid nodules. So you can limit molecular diagnostics to half of the indeterminate thyroid nodules. This is in line with a previous publication by a group from Boston, which concluded that repeat FNA cytology can guide the selection of cytologically indeterminate thyroid nodules that warrant molecular testing. The major changes after 2 years of our molecular testing were the following. 30% of our patients with indeterminate thyroid nodules underwent surgery, which is unchanged from before. But after implementation of molecular testing, the diagnostic yield increased. So this is the malignancy rate of resected nodules. That was our first and most important finding. We did see a decrease in repeat FNAs and an increase in upfront total thyroidectomies after implementation of molecular testing. Our decrease in the number of patients who underwent surgery was modest, as expected, because our resection rate was already low to begin with. And we also saw an increase in mutation prevalence in resected nodules and also an increase of the risk of malignancy in Bethesda 3 and 4 nodules following the implementation of molecular testing. The percentage of total FNAs diagnosed as indeterminates actually decreased since the implementation. This was from 18% prior to implementation to 10% after implementation of molecular testing. And that is quite different from other reports, which showed an increase in indeterminate diagnosis after implementation of molecular testing. Also, we used molecular testing to triage patients. Patients with high-risk mutations had surgery much earlier than patients without high-risk mutations. Most important, we do see a high negative predictive value of our test where we need it most, and that is in ATA intermediate suspicion or ACR TIRETs for nodules. We rarely need molecular testing in low suspicion nodules according to ultrasound because the malignancy risk is low to begin with. And we also rarely need molecular testing in ATA high suspicion nodules according to ultrasound or ACR TIRETs 5 nodules because the malignancy risk is already high to begin with and maybe enough indication to warrant diagnostic surgery. So it is important to focus molecular testing on those ultrasound reports that are ATA intermediate suspicion or ACR TIRADS 4. We also saw a stable percentage of Bethesda categories pre and post ThyroSpec implementation. We implemented ThyroSpec in 2020, therefore you can see two numbers for 2020 here, and you can see that the percentages for B3 and B4 are stable, and also for B3, the percentage is stable throughout the years prior and post ThyroSpec implementation. And that is again opposite to other reports which did show a decrease in Bethesda categories of benign nodules after implementation of molecular testing, and an increase in indeterminate nodules after implementation of molecular testing, which of course then effaces some of the effects of molecular testing. And apparently these cytologies more or less relied more on molecular testing instead of doing their job as a cytologist. We then also evaluated the impact of reflexive ThyroSpec molecular testing on the rates of total thyroidectomies, lobectomies, and completion thyroidectomies, and also the effects on thyroid hormone replacement and surgical complications. As you know, lobectomy is a way of definitive treatment for select cases of thyroid cancer according to the ATA guidelines, especially for patients with thyroid nodules up to 4 centimeters. We used more refined criteria in Calgary based on these ATA criteria. We included patients only if they were able to provide informed consent, diagnostic lobectomies, and we only included patients with Bethesda 5 and 6 if they had nodules of less than 4 centimeters. And you can also see the exclusion criteria, which are straightforward based on family history for thyroid cancer, history for head and neck radiation, or if there was evidence for extrathyroidal extension or lymph node involvement on prior neck ultrasound. The completion thyroidectomy rates pre and post ThyroSpec implementation for diagnostic lobectomy decreased significantly after the implementation of molecular testing, and the therapeutic lobectomy rates were more or less unchanged, and that is mainly due to the fact that this also includes Bethesda 5 and 6 cytology. Therefore, this stable rate of completion thyroidectomies was more or less expected. However, upfront total thyroidectomies increased, and that was mainly based on the detection of high-risk mutations. Only in 5 of the 16 cases, a lobectomy would have been possible, but the patient opted for total thyroidectomy, and in the end, the patient was probably right, because in 4 of the 5 cases, the resulting thyroid cancers were intermediate recurrence risk. So the decisions were probably right, and this was based on shared decision-making with surgeon and patient. We also, as expected, saw an increase in complication rates following completion thyroidectomies. Most of them were temporary complications. This one permanent recurrent laryngeal nerve injury was done on purpose because the recurrent laryngeal nerve was infiltrated. And as you can see, 44% of our lobectomy patients required thyroid hormone replacement. And if the pre-op TSH was greater 2, then this rate increased to 77%. And this was most likely due to Hashimoto's thyroiditis in these cases. However, we don't have any data on TPO antibodies to further substantiate that. The next topic I would like to concentrate on is RAS mutations. And I think this is very important because RAS mutations is the most frequent molecular finding for any molecular test. For ThyroSpec and Calgary, we find it in about a quarter of the tested nodules. And I think this rate is more or less applicable to all molecular tests used. Our malignancy rate for RAS mutations is 51% in Calgary, and this is the malignancy rate for resected RAS positive nodules. As you may know, there's a very high inter-observer variation for the differential diagnosis between benign nodules and microinvasive follicular thyroid cancers. And this then raises the question about what should we actually use as the gold standard? Can we use histology as a gold standard with this high inter-observer variation for histologic diagnosis? And would it be appropriate, or is it appropriate, to call a RAS positive nodule, benign nodule, a pre-malignant lesion? Is this clinically appropriate? And another question is then, resulting from this, is a RAS positive nodule really a true positive? Or is it maybe a false positive if we encounter a benign nodule on postoperative histology? These are major questions and limitations for the determination of true positives and false positives, and also for the determination of positive predictive value and negative predictive value for any molecular test. And just to illustrate this with some histologic studies, if we simply home in on the range of malignancy that we have or should have for Bethesda 3 and 4, we can see that the positive predictive value of RAS findings show a very broad variability. For example, in Bethesda 3, between 10 and 80% in published studies based on histologic diagnoses. And it was therefore more or less expected that the retrospective evaluation of the extent of surgeries in RAS positive nodules frequently resulted in overtreatment. And that was the case no matter if total thyroidectomy was done or lobectomy was performed. Very often these patients were potentially over-treated with the respective surgical strategy according to this publication. And these were all reasons why we adopted a more balanced approach with RAS positive nodules in Calgary. And our standardized reporting based on our 51% malignancy risk for resected nodules then stated that accurate risk assessment should also depend on ultrasound, cytology, and clinical assessment. It does make a difference if this RAS mutation is detected in a 80-year-old or in an 18-year-old patient. And we therefore recommended to refer these patients with RAS mutations to endocrinology to discuss lobectomy or observation depending on this integrated malignancy risk, yet malignancy risk mutations listed here at the bottom of this PowerPoint. And the reasons for this balanced approach is that we didn't want to drive up our resection rates for Bethesda 3 and for cytologies, which was the case in other publications, since we know that our past low resection rates rarely missed cancers. And we can say this because we operate in an integrated, centralized healthcare setting in Alberta. And we also didn't want to drive up our rates of Bethesda 3 and 4 cytologies as previously reported in other settings. And we didn't want to drive up the overall cost of care, of diagnosis for indeterminate thyroid nodules, as also reported in other publications. We've, in addition, now also adopted a strategy of not only reporting the risk of malignancy for resected nodules, but we are now reporting a range of risk of malignancy between those resected nodules and also taking into account the risk of malignancy if we assume that all nodules under ongoing surveillance are benign. And you can see that our range then is between 53 and 35% for all RAS mutations. So we further evolve in our integrated malignancy risk assessment. And these are our revised reports. We now give this range of malignancy between 30 and 50% for Bethesda 3 cytologies, and we also distinguish according to nodule size with our recommendations for observation versus surgery. This is slightly different for B4 nodules, where the malignancy risk is higher, and therefore these cases are then referred to surgery. I think this approach is supported by a recent publication, which also made it to the front page of Thyroid from New York, which showed that only about 20% of the nodules that are RAS positive and are observed, in this case, for about 3 years as a mean, only rarely in 20% show significant growth. And if you look at this more closely, you can see that a really concerning growth is quite rare and maybe only the case in these 3 nodules, which really show accelerated growth in this report. And this then led the authors of this report to conclude that most of these RAS mutant indeterminate thyroid nodules demonstrate stability over time. And of the resected RAS mutant nodules, most were benign. Of the cancers, most were ATA low risk, and immediate surgical resection of all RAS mutant indeterminate thyroid nodules appears to be low value practice. And our results seem to be in accordance with this, since our 3-year data show that nodules with at least 1 year follow-up and stable or even improved ultrasound make up 45% of our nodules for our 3-year data. And we are currently also evaluating our 4-year data, and will probably be able to confirm these data from New York. So based on these data, I think the most important answer for the question, why didn't this rapid increase of reflex molecular testing of indeterminate fine needle aspiration cytologies impact thyroidectomy rates in the US, is probably this binary interpretation of RAS findings for molecular testing, and that is the most frequent finding for any molecular test. We therefore tried to take this one step further, and our analysis of our 3-year data now enabled a multivariate regression for over 1,000 nodules. And this multivariate regression then also included palpation discovery as opposed to incidental discovery on imaging. It also included ultrasound categories, the maximum nodule size, the Bethesda category, so Bethesda 3 versus 4, and also the TIRO molecular testing categories. And based on this multivariate regression analysis, we then also developed a nomogram. And this slide shows the odds ratios. And as you can see, of course, for high-risk mutations, the odds ratios are very high, but the high-risk mutation can only be detected in about 10% for any molecular test. The most frequent finding is these intermediate risk mutations. And as you can see, the odds ratio is much lower for these intermediate risk mutations. And this odds ratio for intermediate risk mutations is in the range of the impact of maximum nodule size or of nuclear atypia, which seems to be a very important determinant for malignancy. And also the ultrasound malignancy risk is of importance, and also palpation and the Bethesda category. And once you've determined these odds ratios, you're then able to also come up with a nomogram, which more or less attributes points for the come up with a combined integrated malignancy risk for your respective nodule based on this nomogram. And this is an example for a nodule. For the intermediate risk mutation, it would attribute about 35 points, 4 points for a maximum nodule size of 3 centimeter, 0 points for B3 cytology, 29 points for nuclear atypia. So this is rated quite heavily. 12 points for ATA intermediate risk or ACR TIROIDS 4 ultrasound classification, and 12 points for palpation versus incidental discovery. So this example then results in a total score of 92 points and an integrated malignancy risk of 77% instead of the 53% for an isolated RAS mutation. And based on these 77%, we are much more likely to recommend diagnostic surgery in this case as compared to the 53% for an isolated RAS mutation. And to take this even further, the use of the nomogram is probably a little bit complicated, and you can then replace the nomogram with an app where you simply input the criteria that I just listed for this example, and then the app will give you this integrated malignancy risk of 76% for the respective example that we just discussed. It is important to note that this app is only a blueprint. This is something that can be applied in Alberta, in Calgary, where we used our outcome data in order to educate this app. However, this blueprint would need to be educated by the respective outcome data for the respective setting in which it is used. So if you want to apply it in New York, you need to know New York data to further inform this app. And then this app can be adapted to the New York situation for New York outcome data. And I think this is much easier to handle than these complicated algorithms that we've previously published in reviews. You can simply input your respective data instead of trying to navigate through such a complicated diagram. So in conclusion, I think it's important to note that optimization of all components, including cytology and ultrasound of a diagnostic pathway for thyroid nodules, contribute to the thyroid nodule malignancy risk assessment. The NPV for our test is highest and most relevant for these ACR Thyroids 3 or ATA intermediate suspicion nodules. Therefore, we should concentrate with molecular testing on these respective ultrasound categories, and especially the most frequent intermediate risk mutations require further integrated malignancy risk assessment. We have thus, with our nomogram or app, we've created a learning algorithm for the continuous improvement based on local data, informing continuous local optimization of our pathway. And I think it's important to note that these evaluations and also our strategy takes place in an integrated single-payer healthcare setting with central access and triage for all endocrinology consults. So all indeterminate nodules are centrally triaged. And the way we do this is discussed in local, so Calgary, and provincial Alberta tumor teams, interdisciplinary tumor teams, which comprise all disciplines involved in the diagnosis and treatment of thyroid cancer and thyroid nodules. And our discussions then lead to further revising of the respective pathways. We use these algorithms also to triage our patients in this setting, not only for thyroid biopsy, as you can briefly see in this diagram, but also for the treatment of our thyroid cancer patients. And as you can see, high-risk patients are then immediately referred to surgery, whereas the intermediate risk mutations require a more integrated approach in our integrated diagnostic setting. So in summary, what is needed is implementation of guidelines, not only for molecular testing, but also for ultrasound and for cytology and for clinical assessment. And once you've implemented guidelines, you need persistent quality assurance, because you can't rely that the next radiologist or the next cytologist who joins the team is as knowledgeable as those that were educated in our discussions in tumor teams and based on the data that we've previously obtained. So it's an ongoing process. We've published this in several reviews. This is also introduced into the European Thyroid Association guideline for the management and diagnosis of thyroid nodules. It's also part of recent textbook articles, and it was enabled by a team of people from several disciplines, and also by the funding by different organizations. And with this, I would like to thank you, and I'm looking forward to the discussion.
Thank you, Ralf. Happy to jump in and just give a few thoughts and comments and provide a little perspective. I know time is running short. I'll flip through a few slides here just to always note that I've been involved in this space, so my necessary disclosures, research, consulting, and other things for over a decade. You know, I think the starting point when we talk about molecular testing and its impact on thyroid nodule care is to acknowledge that molecular testing means a lot of things. I like this slide because early on, we took the basic cellular biology that DNA is transcribed to RNA, translated to a protein. We've long known there's this inhibitory bucket of microRNAs that inhibit the last step. But you know, early on, even a decade, 15 years ago, we began to see the clinical translation of potential molecular targets in each of these domains into the clinical realm. So it means a lot of things, and it's expanded rapidly. We now know there's mitochondrial DNA, very important to Hürthle cell disease. There is other non-coding RNA that circulates that seems to be increasingly important, and there's post-translational modifiers after the last translational step has occurred. So it is a big bucket to simply say molecular testing. I would also acknowledge, as Ralf had mentioned, that our basic approach to a nodule was a bit oversimplified. This concept of an ultrasound, a TSH, and then a movement to a nodule biopsy on the bottom right of the screen most of the time is simply oversimplified, acknowledging that there's now complexity to each of these domains. So that is kind of the introduction here to provide a little perspective to Ralf's important editorial, and then really based on, of course, the primary data from Huang and others. And I would acknowledge this is a really important question as to how we're using this in the clinical domain and thinking about molecular testing, which has come forth very quickly. The Huang data looked at a very large database of over 500,000 people, and it was very logical in linking trends in FNA to surgical thyroidectomy. I really liked Ralf's editorial, and what we expected to find isn't exactly what we saw. So why is that? But the cautionary piece in overinterpreting the conclusion is to acknowledge the complexity of what we're dealing with. There are many factors that drive decision-making in clinical care, and Ralf alluded to many of them. I would also acknowledge, and I'll show you here upcoming, that the study investigated data that was from 2011 to 2021. And that is a period of time where we saw rapid evolution of numerous different tests in the molecular clinical sphere, many of which were not really ready necessarily for prime time. And so the data may not fully reflect the benefits that we're seeing now in 2025. I would also acknowledge we have to just be a little cautious that perhaps the conclusion was actually a reduction in thyroidectomy rates, and the association that perhaps the molecular testing didn't exactly correlate is interesting, but it may not directly be causative. So as just to reemphasize my approach, and I think what Dr. Paschke said very well, is that as we think about the approach to nodule care, we are really trying to integrate so many different domains. There are demographic risk factors, radiologic risk factors, cytologic, and now molecular that come together, some for initial risk determination, other for risk refinement, and we're trying to optimize. But we know that there's also limitations to each, and that really is the complexity to what we're dealing with here. Early on in my career, this dates back now about 15 years, we began to understand that we had good data on the univariate analysis of understanding how each variable was playing into nodule risk. And we published this in JCEM, and we've updated this now in Lancet Diabetes and Endocrinology. So the univariate understanding of risk relation and risk adaptation is well understood, but the multivariate process, which Ralf was alluding to, is more complex. I do think if you go back to when I entered the field, we were quite simplistic in terms of how we approached a nodule. Anything over a centimeter seemed to get an FNA, but it's very different now in the current era, and I should, of course, update the slides to 2025. That we have many diagnostic tools, we have many different diagnostic steps, but probably most important are the diagnostic considerations that all have to be integrated together. In the current era, I like to say we're guided no longer by what we can do, but what we really should do. And I want to just take a step to acknowledge, too, the world we're living in as it relates to molecular testing is very complex, and it's complex for several reasons. Some of which I've alluded to. It's a lot of different things, but also the process in which it comes and translates into our clinical offices. Because there's been rapid utilization and rapid evolution really over about 10 to 15 years. From discovery of these tests to analytic testing to validation testing, and arguably right now in this era of clinical utility assessment. So what are those challenges really coming forth? Why do we see them? Remember that when you're dealing with a molecular test, unlike a pharmaceutical new drug, if you will, tests will come to market very quickly without the phase 3 equivalent data that we would expect on a new pharmaceutical. And so the real world practice also becomes a lot more complex sometimes than the data that led to the publication and then the kind of utilization of the molecular scenario. And we should note that out there in the molecular space in the United States, frankly, worldwide, there is not a single really head-to-head trial where 2 or more tests have been applied to the same aspirates to understand true comparative analysis. In fact, I like to show this slide. When I look at the data, these are the 7 or 8, if you will, high-quality trials that people would say are prospective, have 2 or more sites, and are blinded, applied to Bethesda 3 and 4 with various molecular tests. And I show their so-called claimed conclusions, the negative and predictive values. So I will ask you, because I'm often asked, tell me which one's the best, because they all look awful similar, don't they? I don't have time to go through all of that, but I will tell you, based on just the quality of data and then the utilization data after, I would argue in the US, we really have 2 active molecular tests that are commercially being brought forth. One is going to be the ThyroSeq 3rd version, V3, and the other will be Veracyte's gene sequencing classifier. But again, these are very different than the first generation tests that were being looked at starting in 2011 in the data we just talked about. And let me show you why that's so important. When you actually look at the published initial data that would have been coming forth here, as you see in 2010 and 2011, and what really then is being seen when we use the test in the clinical world in 2020 and beyond, we're not seeing them match up. Look at the data initially on these pilot studies that came forth. The Chudova study was the precursor for the Afirma test. The Nikiforov data, 2011, was arguably the ThyroSeq version 1. They were really good. They were near perfect tests, right? But that's just not what then showed. If you look here at the ThyroSeq, if you will, version 2 equivalent, and you look at numerous different publications that showed the real world data, positive and negative predictive value, you see that positive predictive value plummet. It was not matching the initial so-called initial validation or data. And why was that? Well, a lot of it had to do with what Ralf was saying. There was a lot of assumptions that certain mutations meant something was malignant, and in particular in the atypical Bethesda 3 category, the RAS positive mutations were assumed at times to be malignant. That just is not the case. Dr. Paschke showed that. We have seen that. I note here the meta-analyses by Martha Zeiger's group. Everyone is essentially showing about 50% of RAS positive nodules indeed are benign. And as Ralf also showed, the assumption that a RAS positive benign nodule is premalignant is not yet really verified. Many of these do appear to have long-term benign appearing kind of nature to them. But I don't want to make this only about the ThyroSeq story and the DNA-based test. You can find the same in the RNA-based test, which is more the Afirma data. The initial Chidova data, which was the precursor to the Afirma gene sequencing classifier. When you look at the actual downstream validation, it was not the same as what we saw. It was much worse. A lot of that also had to do acknowledging that we went through this period not understanding why the tests were not performing as well on Hürthle cell lesions or lesions with Hürthle cells in them. And that was largely because these data in 2018 demonstrated to us that Hürthle cell neoplasia, both benign and malignant carcinoma, are driven by completely different molecular tests. So obviously those would not have been in play back in the early data. So there's a lot there that I ran through quickly, but I'll acknowledge here in 2025, my view of nodule and cancer care still surrounds the basics of ultrasound being so valuable and the concept that we don't want to overdiagnose and intervene on a hot nodule. But we're learning how to use fine needle aspiration, cytology, and molecular analysis much better for the goal of understanding truly the tissue phenotype and then using it not only for initial diagnosis, but prognosis. Through all of this, though, we're learning to limit intervention. We're learning the value of watchful intervention and watchful observation. I think as we've both gone through the power of synergizing your numerous variables, of intelligently using molecular data, acknowledging it's quite complex, thinking prognostically more than just diagnostically, and emphasizing the shared decision-making model. So with that, and 2 minutes left, I'm going to stop and turn it back over to Mark.
Well, thank you very much. That was absolutely terrific. I came away listening to both and having reviewed the Huang article and several others, wondering whether or not payers in the United States certainly are going to require a second fine needle biopsy before agreeing to pay for molecular testing. Maybe if you could just comment on that, because that seems to be somewhat of a logical conclusion. Maybe Ralf, if you want to start with that, and then Erik.
Well, maybe Erik should comment because I'm not based in the United States.
I think it's a really good question, and I think if you're wearing the payer's hat, you probably would say yes. That's exactly what we should do because that is a way to slow the system down. And generally, when you're dealing with a low-risk malignancy potential, that's a good thing. Anything that slows it down and is more thoughtful and integrated, as Ralf was showing, is a good thing. The downside to this, and I'll just play devil's advocate on both sides, which is there are absolutely good data, as Ralf has shown and as Ralf has replicated, that indeed you can simply obtain often a better sample or a broader sample on FNA cytology and do a better job reading out the low-risk Bethesda 3A atypia, especially when it's based on limited cellularity. But there's a whole flip side argument to this, which is we should never anchor that any test can just become better by doing it more. There's a natural limitation, and the data there, I always go back to is Ed Siebe's paper in the Annals of Internal Medicine, that if you looked with experts blindly looking at FNA cytology and said, okay, your first expert read this as Bethesda 3 atypia, if you simply send those slides to somebody else, you have a 2 out of 3 chance that they will read that same exact slide differently. Even if you sent the same slide back to Ed Siebes to read the same thing twice, he would not read it as Bethesda 3 about 20% of the time. So there's a natural error in this process. That's similar with ultrasound. That's similar with physical exam. So the argument against simply arguing 2 biopsies is that you're kind of rolling the dice randomly. If you also send a new sample to someone, you can't be assured that it's precise. That's the problem.
So Ralf, I'm going to ask you the final question, and that is 5 years from now, what will the workup of indeterminate cytologies look like? Can you project ahead here?
Well, that's a difficult question. I don't have the crystal ball, but I think what we will probably see is the pendulum swinging back a little bit in a middle position. I think currently we are overusing molecular testing. I think we will use molecular testing in a much more focused way. I think that is foreseeable, and probably our tests will also be better. But I think this is of less importance. I think it is more important to use molecular testing in a more integrated way. And I think that will probably be the case. And this is mainly driven by cost and further insight.
Terrific. Well, unfortunately, we are up against the 9 o'clock hour here in New York, and I just want to say thank you to both Dr. Alexander, Dr. Paschke for really wonderful presentations, and invite our listeners to circle back with us next week for another presentation. And everybody, Happy New Year. All right, thanks again.